Healthcare careers shouldn't be a mystery, and they shouldn't be reserved for people who already have connections or know the right people. My name is Tanvi, and this is Healthcare Unveiled, where we have honest conversations with healthcare professionals about their real journeys, the good and the challenging parts, so that you can figure out if and how this path might work for you. Today we have Dr. Anderson here. To begin, how are you, and can you tell us just a little bit about who you are and what you do?
Sure. My name is Jean Anderson. I am an obstetrician gynecologist at Johns Hopkins. I am now a professor emerita. I've as part of my failed retirement. I've retired from clinical practice, but I'm still heavily involved, particularly in global health and HIV. And most of my work, clinical and academic, over almost 40 years has been spent in HIV.
So, what initially drew you to medicine and specifically to HIV and obstetrics? How did you kind of get to that point in your career?
Well, I don't remember a time when I didn't want to be a doctor. So I was very focused on becoming a doctor from the beginning. And my parents were very, very supportive of that, even though at that time there weren't a lot of women who were going into medicine. So other people would say, "Oh, you mean you want to be a nurse?" And I said, "No, I want to be a doctor." I came into medical school, went to medical school at Vanderbilt in Nashville. And I came into medical school thinking I wanted to be a psychiatrist. And then during my clinical years, the very first rotation I had was in surgery, in general surgery. And unexpectedly, I found that I just loved surgery. And then my second rotation was in psychiatry. And although I enjoyed it, I decided that didn't fit me, didn't fit my personality and what I wanted to do with my life. My third clinical clerkship was OBGYN. I'd never even considered it, but I loved it, partly because it was a real combination of medicine and surgery, preventive care and treatment. Includes a lot of ethical issues, includes a lot of psychiatry too. So that's what drew me to OBGYN.
You talked about how people were kind of discouraging when you said you wanted to be a doctor because of your gender. So I was just wondering, what was it like being a woman in, for example, like medical school and trying to go into OBGYN at the time?
Well, I was probably in a good time. I really was encouraged. Vanderbilt was great. My professors were encouraging. There was no problem there. Interestingly, I think that there was some pushback occasionally from patients, from women who were happy to see me. This was infrequent, but it happened. They were happy to see me for like routine care, but if it came to the point of needing surgery, they wanted a man. And so I decided very early that I wouldn't really tolerate that. I was a trained surgeon as well as an office a gynecologist. So when that did happen, I referred them and I said, referred them to someone. I said, but I said, I'm transferring your care. I made it clear that if they want to see somebody else, that's perfectly fine. You should have trust with whoever you see, but I wasn't going to put myself in a box of just doing office exams.
Yeah, that's interesting because I feel like today people would much rather prefer a woman doing OBGYN care over a man.
I think that's been an evolution. And in fact, more if you look at residency programs and who goes into OBGYN now, it's by far and away women in the majority, and almost to the extent that it's really not healthy. We should be looking for good and well-trained doctors. Gender is not an issue, should not be an issue in choosing a doctor. So at Johns Hopkins, when we have interviewed and looked for new residents, we have actively tried to have a little bit more balance. But it's definitely very female predominant now.
So in 1991, I saw that you founded the Johns Hopkins HIV Women's Health Program, which is one of the first of its kind. So I was just wondering, what made you realize that there was a need for specialized care for women in terms of HIV?
Well, so let me put things in a little bit of time perspective. I graduated from medical school in 1909. AIDS had not even been identified, so I never learned it. I learned about it in medical school. I never saw a case in residency. After my residency, I stayed on faculty at Vanderbilt for about 3 years before I came to Hopkins. Never saw a case. And the first cases of AIDS were not identified until 1981. And that was in gay men. The first case in women was, I believe, 1982. So it wasn't until I was almost through my residency. And at that point, there were still centers in the country where there were more, you saw more people who were infected with HIV. We didn't even know what caused it initially. And so the South, which leads the country now in new cases in women, you didn't see it very much. I'd always been interested in infectious disease. And when I came to Hopkins, I got a call one day. So I was still fairly, I was within 6 months of arriving there. And I got a call one day from the one person I knew there when I arrived, who had been an infectious disease fellow at Vandy. And she said, we're beginning to see just a few women with HIV, and wondered if you'd be our gynecologist. So that's how I started. I knew nothing about HIV, but these were women who needed health care just like anyone else, including gynecologic care. They were getting pregnant. We learned fairly early on that HIV could be transmitted from mother to baby. So there was a need, and I liked infectious disease, and I have always particularly been attracted to caring for women who are who have been more oppressed, who have been discriminated against. I did that in Nashville when I worked at the Nashville General Hospital. Minorities, poor women. So it was just and here was a new disease. So it was really, I felt very fortunate to find it, but it was really serendipity. I mean, I was at the right place at the right time. So I started the program. I actually started a little sooner than 1991. I started seeing patients in the clinic in 1988. And then gradually, at first it was only me, but it quickly ballooned into needing other providers and a lot more women.
Thank you. So starting a new program like that must have been very daunting. So what kind of obstacles did you encounter originally, and how did you convince the institution maybe to support your initiative?
Well, when you're in academic medicine, you generally have to find funding to support you. Now, you can see patients and you bring in part of your salary that way. But usually in academics, you're expected to do other things, teaching, do research, but you've got to make the money to pay for your salary. And so part of it was, as I said, the right time. I had just arrived. I didn't really have a niche, something I was already, I was still pretty junior as a OBGYN and as a faculty member, and probably pretty naive too. And so I asked permission to start seeing patients in the AIDS clinic, and my chairman was very supportive. But there came a time when it's like, okay, now you got to bring in money to support the time you're spending. And a lot of the women I saw were poor. They had little to no insurance. So it wasn't like I was able to bill and bring in money that way. So I started asking around. AIDS was growing by leaps and bounds, and the public health response was also growing because it was a real epidemic. And so I contacted the Maryland State AIDS Administration, first of all, and there wasn't any funding. I was looking, this was prior to the Ryan White program. And then one afternoon, I got a call from the head of the State AIDS Administration, said, we're just getting some funding and we'd like to support you, but I need you to write this is very short notice, but I need you to write a proposal and I need it tomorrow. So I stayed up all night and wrote it, and that's how I got my first funding. And my program has been fully funded since that time. So that's how I really was able to support the program and have the support of the institution. That's nothing unique to HIV, but it's just the way things work when you're in academic medicine.
Thank you. From what I saw online, your program has treated over 1,500 people over the past 3 years. So I was just wondering, what has kept you motivated to continue this work for so long? And do you have any specific stories with patients or people you've worked with that you would like to share?
Sure. Well, and I don't know how many more we've treated since I could tell you many stories. I'll tell you a few. Early on, everyone died. I mean, this was uniformly fatal. This was prior to the development of the first antiretroviral agent, which was zidovudine, known as AZT. And it was also a highly stigmatized disease, not only by the general population, but by other physicians and nurses. And so those of us who provided care were often stigmatized. I remember at that point in time, I had residents who didn't want to operate with me because I operated on a lot of women with HIV. There was just great fear. And the AIDS service at Hopkins actually hired a psychologist for us. So we had like for us, the providers. And we had weekly meetings. We went on a weekend retreat. We were a great source of support. And I can tell you that to this day, so almost 40 years later, my closest friends and my partner come from those days. In fact, I'm now in a book club, and all of us first met and became close through the AIDS clinic. So that's from the provider end. I'll tell you about one of my patients her name is Rose, and she has given me permission to talk about her. And this was early on. I delivered her, and this was, again, prior to antiretrovirals. And about 2 months after her daughter was born, she started getting sick, the infant, and was ultimately diagnosed with HIV. So she was perinatally infected. Now, Rose had never used drugs. She had no idea how she could have gotten infected. She talked to her husband, who, denied that he was infected. And then one day she came home and found him shooting up. And it turned out that he was infected and had never told her. And that's how she got infected. And then she infected her daughter in utero. So Rose was so spooked by this and so spooked by the healthcare system, she did not want to go to an HIV clinic. So I offered to see her in the GYN clinic. And for at least a couple of years, I followed her there. But I always told her there's going to be a time when you need to be seen by an expert in, again, just beginning to see some drugs. I said, but, if you start getting sick, I'm not going to be the best person to take care of you. And so, but kept working towards her agreeing to be seen in the AIDS clinic. And I said, I can see you there. I see patients there. So that's what happened. And she finally came to the AIDS service. And I was getting a little bit more funding somewhere around this time, and I hired her as one of my peer counselors, one of the first two. And their job at that point was really to give support to other women who had HIV. So fast forward a number of years. Well, till around 1996, 97, Rose started getting sick. And fortunately, this was right when HAART, or highly active antiretroviral therapy, came in. That's the concept that you combine antiretroviral drugs, which each one of them hits different parts of the life cycle of the virus. And that's how you get control of the virus. It's not a cure, but you can suppress the virus to undetectable levels. So she started getting sick, but it was right at that time. So today, she is still a counselor in my program. Her daughter is now a nurse practitioner. And so, it's one of those success stories that I love to talk about. And Rose is one of my very closest friends. So I think that's one of the best stories I could tell you because it demonstrates what we've come from, but where we are now in terms of not a cure, but a lot of hope. And Rose actually going from being like not wanting to see anybody and not wanting to talk about HIV and not wanting to disclose to anybody, she's spoken all over the world now and told her story and talked about HIV.
It's awesome. On the theme of like stigma and education, you mentioned that Rose originally was kind of afraid of going to a doctor or like a clinic. And I know that's a pattern that we see a lot these days. So I was just wondering, how would you, or what's your perspective on that issue, and how do you think that people can kind of move forwards in trying to make hospitals or healthcare like a less scary phenomenon for patients?
Well, I think HIV is unique in some ways because the people who in the US in particular, as opposed to where there is a more generalized epidemic in, say, much of Africa, but in the US, it struck first gay men, then injection drug users, then people of color, none of whom had a real purchase in the healthcare system in this country. They often didn't trust for good reasons. They were stigmatized for who they were. And so the stigma was great. Now, what changed the stigma was, and we were dealing with what changed the stigma to a large extent was treatment, effective treatment. People with HIV now, if they are diagnosed and get appropriate treatment, right now that treatment has to be lifelong. But if they stay on that treatment, they take their medicine as it is prescribed, they can live a near normal, if not a normal lifespan. And so it's tamped down a lot of the fear. So I think education, because all of that is certainly because of incredible medical advances, but then it's really a public health issue. It's getting that word out. It's normalizing people who have HIV. And in fact, we nowadays don't say an HIV infected person, we say a person living with HIV, because that's what they're doing. And rather than defining them by their disease, it's just a part of them. And of course, there's been a lot more advances now, better treatments, easier treatments. I mean, it used to be when AZT first came out, it was like a handful. It's like 5 pills 5 times a day. And then some other drugs came along and you still had just loads of pills to take. And looking at that for the rest of your life, I don't know about you, but for me to finish a 10-day course of antibiotics is tough. Then you're talking about medications, particularly the older medications that often had side effects, as well as the people who were living with HIV were afraid afraid to tell people. So if they were, they would hide their medicine or they wouldn't take it if they were around other people, which of course just meant that they were developing resistance and skipping doses and things like that. So nowadays, there are several regimens that are 1 pill once a day and much better tolerated, less side effects, fewer side effects. There's also incredibly effective preventive measures. So we've come a long ways, but I think when you're not in the field, you may not, even as a healthcare provider, you may not know that so much. So I think it's constant education. It's, this is not the way HIV was in the old days. And I think it's also normalizing people who are living with HIV. Media has been incredibly important in that, normalizing gay relationships, talking about treatment for drug use. Women have always been under-recognized, I won't say minority because we're not a minority, but have not had the benefit. This is in the US as well as globally, sometimes of the same educational advantages, the economic advantages. And even with HIV initially, women received attention because they were either sex workers or because they were mothers who might deliver an infected baby. I remember one lecture I was giving, and I put up a slide and just left it up there for a minute. It made everybody uncomfortable, but it just said, women are more than mothers or whores. And because that's how it was looked upon. So I think whatever advances we've made in women's rights and recognizing the value of women has also helped. Maybe going a little backwards now, but it's been incredibly important.
Yeah, thank you. Generally, you work with some of society's most vulnerable patients. So how do you balance the emotional weight of that work while also maintaining professional effectiveness?
I don't think you can totally turn off and you shouldn't, your humanity, your emotional aspect when you're seeing patients. They're whole people. And you can give them treatment that we know is absolutely effective. But if you don't deal with their homelessness, their substance abuse, their depression, the violence they're experiencing at home, the treatment's not going to be effective because they're not going to take it. So first of all, it's sort of an artificial distinction. I love taking care of these patients. I love these patients. And I have an emotional investment in them just as I think they do but yes, you have to take care of yourself too. And you can't work all the time. I think it's important to have a life outside of work. I'm a real outdoors person, hiking and biking, and I love to read. And I used to struggle not to work constantly. And so I'd carve out some time, like some evenings where I didn't do any work, things like that. So I think the answers are individual, and I maybe sound like I'm saying two different things, which I am in a sense. You can't protect yourself from the emotion of doing this work. And that's not just in HIV, but in medicine in general. All of your patients are people too, and you too will likely one day be a patient. So it's important to have that more holistic vision, but at the same time, to maintain some boundary between your work every day and your life away from work.
Thank you. To kind of close off, this is something that we ask, or we try to ask everyone that comes on the podcast. But if you could change one thing about healthcare, medical education, or in general how we approach women's health, what would it be?
It's a really good question. I think the thing that worries me most about medical care these days is it's become such a business industry. And even when you're in the midst of academic medicine, you're pushed to fund yourself or to make money. We have the electronic patient record in most places now, which has been a real godsend in so many ways. But the programs we use are clearly designed to get the most out of billing. And you find yourself, I'm looking at you over the computer. If I had a patient and I'm typing into the electronic record, I'm not looking at them. They're over there. And so there's all of these tools that have made our lives easier in some ways. Also, I think present further boundaries or barriers rather between us and our patients. So I think that and I think there is a real effort in medical schools now to humanize medicine more. And I think that's going to be a constant struggle because medicine keeps expanding. There have been just incredible technological advances. When I was a medical student or a young resident, laparoscopy was just in its infancy. And now most of our hysterectomies and other abdominal surgeries are done robotically or laparoscopically, so with minimal invasive techniques. Those are really positive developments. Women, the surgery, they go home faster, they recover faster. So there are all of these advances. There are advances in pharmaceuticals, as you know, but then at the same time, our healthcare is too expensive. It's complex in terms of just trying to negotiating, insurance and things like that. And it's expensive. So I guess it's kind of a round the world way of saying, I think we need to constantly humanize medicine and realize that really develop humility. And secondly, try to do something that I'm a firm believer that healthcare is a right, not a privilege, and find some way of making healthcare be more accessible, higher quality, and more acceptable to patients. One last thing I would say is I would say this to any student, resident, attending, whoever, you've got to keep learning. Remember, I said at the beginning that I never learned about HIV, never saw a case of HIV, and yet I've spent 95% of my career in HIV. So I had to learn about a completely new disease and had to keep learning because what we know keeps changing. So that's you don't learn everything in medical school and then that's it. You have to keep learning, and I think there's a great deal of humility to be garnered from that.
Thank you. Yeah, that's the thing about healthcare being kind of expensive is something that I've noticed too, because I've lived in a lot of places growing up, and something that I started like noticing, especially after coming to the US, was how in places I've lived before, going to the hospital or seeing a doctor was kind of like the first thing people thought of when they got sick. Whereas here, it's kind of like a last resort because people just want to figure it out on their own before they see a doctor. So yeah, that was really interesting to hear about. So yeah, thank you so much again for coming on today. One of my biggest takeaways from hearing you talk today was that healthcare is really all about humanity and that medical advances in terms of research can't really mean anything unless you have doctors that are empathizing with their patients and kind of taking that research and translating it into healthcare. So I hope whoever's listening can also take something away. Thank you so much again for coming on today.
My pleasure. Thank you for inviting me.